Can y'all hear me now? Perfect. All right. So I know this is going to be a very kind of heavy and long topic, so I'm going to try to jump right into it. This discussion of, intersectionality of pandemic and protest, the shared vein of systemic racism. Um, I don't think this needs an introduction. We all know what 2020 has kind of looked like, and it's kind of turned our idea, I think, of what even America means on end. So before I do get started, though, I do want to share that my name, it literally means Black. I am a Black woman, but this is my 23andMe results. And as you can see, I'm basically like the United Nations personified. And I say all of that. I shared my DNA with whatever Chinese or Russian agency wants to use it, for the simple fact to say that I do come in peace. And I say that because we're going to be talking about some very heavy information. And usually when we're talking about race in particular, it causes some friction. So everything is said out of love, and everything will be based on data so we can keep emotions kind of out of it. But let's just start. So we should have known from the start that 2020 was going to be kind of crazy, because we started with an impeachment trial, and soon thereafter we had the passing of Kobe Bryant. And Kobe meant a lot to, I think, the country in totality in the world, but he meant a lot to the Black community. And at that point in time, I said, okay, I think 2020 is going to be rough, but this has to be the end of it. And then we had this onset of this pandemic, right? And so most people may be thinking at this point, well, why am I even here? These two things, pandemic and protests, they're not related at all. And then other people may be saying, okay, I get it, because we had a protest in the middle of a pandemic. And so I see where we may have overlap. But I want you to know that I think both of these things are actually a little bit off, and that it's not two separate things interwoven, but these two things, the pandemic and protests, are actually the same thread. And I hope by the end of this, we'll kind of see that. So let's just start from the very beginning, and we can go fast through this, because I think everyone at this point knows what COVID-19 is. But we do call it several different things, the disease name being coronavirus disease 2019, the scientific name being SARS-CoV-2. And if there's a 2, that means there was a 1. And you guys may remember in 2003, there was a epidemic that was primarily on the Asian continent, where they had about 9% mortality, with 774 people passing away, unfortunately, between 2002 and 2003. Now, the coronavirus, we know coronavirus, it looks like this. It gets its name because it looks like a crown, but there are literally thousands of coronaviruses. Only 6 of them are known to be transmittable between humans. 4 of them cause your basic sniffles, with 2 of them being the more deadly forms of MERS and SARS. And so this is the what. Now, when did it start? So it started here in Wuhan, China. And in December 31st, actually, Wuhan, China called the Chinese government and said, we've had dozens of these pneumonias, and we're not sure what's causing them, but people are dying at a faster pace than we typically see. They had their first death actually on January the 11th. Soon thereafter, we actually had the World Health Organization release a situation report, because unfortunately what we saw is that it was no longer being contained to mainland China, but we were seeing cases in Japan, in South Korea, and in Thailand. And on this same day, oddly enough, United States had our first case on January 20th. We reported our first. Unfortunately, around this time in China, there's a huge celebration for the Lunar New Year, where hundreds of millions of people literally go and visit other family members. And so before we really knew how dangerous this virus was, there was a lot of traffic and spreading of the virus around. So that's what kind of let this spark. So to keep this timeline in place on the United States in focus, we had our first, again, COVID-19 case on January 20th. On January 30th, you can see this progresses really fast, because the World Health Organization declared a global health emergency. On January 31st, Trump had a restriction on travel. And this is kind of a partial restriction. There was another 40,000 people still allowed to travel throughout China. On February 29th, we had our first death in the United States. And this is when I knew in my soul that Black people were going to be in deep trouble. And I'll show you about that later. On March the 13th, Trump declared a national health emergency. And by March 20th, simply 66 days later, the United States became the world leader in the number of COVID-19 cases, and we had our first 1,000 deaths. Now, what does that bring us to today? Well, on September 23rd, we're at 243 days later. We have 7 million, and 7 million is supposed to be 90,291 cases with 205,491 deaths. Now, what does this look like in totality? I know we've been throwing a lot of numbers around and we compare it to the flu, but if you look in the previous years, this is the mortality rate or the cases of mortality we see in the United States. And this is in 2018 here, 2019, and 2020. And you can see in 2018, we had a really bad flu season. But for the most part, we're able to estimate exactly how many people we think will die from year to year of the flu, and then other things like cancer, heart attacks, you name it, right? And what we're seeing is here in 2020, we have had a huge upsurge from this COVID-19. Keep in mind, this is only dating to March or May the 30th on this graph. And this is going to be key in the next couple of slides as to why that date is so important. Now, in these numbers, when we say 205,000 people, what does it look like? Well, in the last 7 months, we've had more people die from COVID-19 than we did in the first 8 years from HIV/AIDS. If we are looking at an Airbus, this is an Airbus 308, it carries 544 people. We would have to crash this Airbus for 373 days, full of people to match the number of people that we've had die from COVID-19. To bring kind of closer to home for me, I've lived in 3 cities since I've been alive. One is in Spartanburg City, right? The other one is I did all my training in Charleston, South Carolina, and then now in Charlottesville. And if you take the population of the cities of Spartanburg, the city of Charleston, and the city of Charlottesville, that's how many people we would have to collect to equal the number of people that have passed away from COVID-19. Now, again, I want to highlight this graph. We know that there's been several more people that have passed away following May the 30th, but I chose this graph for a certain reason, because for Black people, this has been a double hit of a year, because not only are we dealing with the COVID-19, but 5 days before this May the 30th, we also had to deal with this. Well, let me go on through this. This is how it spread. We all know that. But we had to deal with this idea of everyone else. The world kind of came to a stop, and people, were no longer going to work, and they were becoming these Zoom experts. But our mortality rates were continuing to climb. And one of the things we had to deal with 5 days prior to the end of that graph was the death of George Floyd. So everyone saw, for 8 minutes and 46 seconds, the world kind of stood still as we watched the knee on the neck of George Floyd. And just to kind of bring home the point of how long this is, I'm going to set a timer for 8 minutes and 46 seconds so we can see just how long that was. And this left a huge mark for African Americans, because he wasn't only passing away of this year. We also had Breonna Taylor that we've been hearing a lot in the news here of late, right? There was a no-knock warrant that was issued, and she was murdered inside her home at midnight as they entered into her home searching for evidence on another case they were working on. And then we also have Ahmaud Arbery that we watched as he was jogging through his neighborhood, and the vigilantes that murdered him was an ex-police officer. And it was one of these moments where we were all stopped long enough in this pandemic, not going to work, right? Stuck inside of our homes, and watching this murder kind of hit us in a different way. We know we've been screaming Black Lives Matter, and I think this cover that the New Yorker really highlights an important point, that this screaming of Black Lives Matter, it's not just a recent thing. It's the same screams that were done back with Emmett Till, with Martin Luther King, and with Malcolm X, right? It's the same screams that were done back with Nat Turner and Denmark Vesey and the slave revolts back in the 1800s, right? It's the same scream. It just may sound different, but we use different terminology, but it's the same thing of see me as a human and treat me as an equal. But the difference this time with the Black Lives Matter movement, is that the entire nation was stopped, right? Everyone was in their home and they were able to witness and view this video. So instead of it just being primarily Black people taken to the streets to say Black Lives Matter, we were now joined by many people who did not look like us, white, Hispanic, and Asians, to say that Black Lives Matter and this is not right. And in fact, it wasn't just our United States allies. What we saw is that because this was a global pandemic that was happening, that other nations and other countries, from as far as Tokyo and Amsterdam, joined in this movement to say, hey, Black Lives Matter, stop. And the question is, what would make you risk your life to go into the streets in the middle of a pandemic and risk exposure to yourself of this deadly virus? What can be that great? Well, it's because for Black people in particular, what we know is that there's two kind of pandemics we're facing. If we're looking at, and I'm going to say this is where the intersection of these two things happen. If you're looking at police brutality, the lifetime risk of being killed by a police officer, this is looking for Black men versus white men. You're 2.5 times more likely to be killed by a police officer if you're a Black man versus a white man, right? If we're looking at COVID-19, this is looking at age-adjusted risk for Blacks versus white. Is President? Okay. Somebody's requesting something. Age-adjusted for the races compared to whites. And if you're Black, you're 3.4 times more likely to die from COVID-19 than if you're white. Latinos, 3.3 times more likely. Indigenous population, 3.3 times more likely. Now, to put these two things that seem like they shouldn't be related into perspective, what we can see is, and I'm not sure about this annotation. There we go. Over the life course, to say it in a different way, 1 in every 1,000 Black men can expect to be killed by police. I'm going to say that again. Over a life course, 1 in every 1,000 Black men can expect to be killed by police. And as it stands now, for every 1,020 Black people who were alive in January, one of them has died from COVID-19. Now, for me, these two numbers were too similar to shake to say that this is just a coincidence, right? That something else is happening. But I always try to figure out the why behind it. Like, why is this happening? Maybe maybe it's just that we are more violent. Maybe that's what's happening with police brutality. Maybe we are coming into contact more often and we're the aggressors. Well, in looking at this is the FBI's report of 2017. And they break down what are all the charges and then what's the racial makeup and distribution of these said charges. And what we see is that Caucasians actually account for 68% of all arrests, 67% of all rapes, 58% of all violent crimes, 71% of all arsons, and 67% of all burglaries. As far as the juveniles, again, 56% of property crimes, 74% of drug abuse violation, 54% of aggravated assault, and 57% of larceny and theft. But when we're looking at who gets killed by the police, we see, as far as their U.S. population demographics, African Americans are killed at nearly 3 times what their population density is, right? Whereas Caucasian Americans are killed at less their population density. If you're looking at unarmed victims of police killings, so this is what your general population percentage is as far as Black, Caucasian versus minority populations, right? When we're seeing the unarmed victims, these are people that are not with a gun, they're not with anything that can be life-threatening to the police officer, and yet if you're a minority, you're more likely to be killed than if you are a Caucasian. So, this brings up a very troubling statistic for me, that for Black men aged 15 to 34, you're 9 to 16 times more likely to be killed by the police than any other people, 9 to 16 times. And, the killing is one thing, but I think it's the in-between that also we need to take into account, because you see, this is Philando Castile. He was, as you know, or may remember, years ago, he was also murdered by a police officer. And this is the scene. And I was not going to show this graphic picture because it is troubling. But the only reason why I do think it's necessary for us to see is because in the backseat of the car was his 4-year-old daughter. And she had to see this and witness this. So as adults, if she has to see it, then so should we. So we can figure out how to stop this. Because One of the things that she said as she was comforting her mother in the back seat of the police officer's car, and this was the first time the mother was actually expressing emotion and started to cry. And this little 4-year-old kept saying on the record, you know, don't cry. I don't want you to get shooted. She kept saying, don't cry. I don't want you to get shooted over and over again. And it troubled me to my core, because why does this 4-year-old already associate with death? Right? What does that do to your psyche? What kind of trauma happens with that? With Philando Castile, before this day, he was actually pulled over 52 times in the last within the last 10 years. And my question is, I've only been pulled over, I can say maybe like 3 times. What does being pulled over and targeted and profiled that often, what does it do to your mindset? And my question is, does PTSD only apply to soldiers, or do our Black children in our Black community not qualify? Because we know that there's things that happen, right? We know that there's triggers of if you're constantly being targeted. Your body is naturally set up to have a fight or flight system, the HPA axis, right? You see the threat, your hypothalamus talks to your pituitary gland, that talks to your adrenal gland, that says fight or flight, you have to do something different. So you release the cortisol, the glucagon, the catecholamines. And what does that have on the impact of your body? Well, we know for the heart, we have tachycardia, hypertension, right? We know for the kidneys, we have retention of sodium and water, increased blood volume. For the liver, we have gluconeogenesis, we have increased fat mobilization, immunosuppression, and obesity. And as far as the pancreas, decreased insulin sensitivity, right? As far as what the insulin it produces. And if this is in the diagnosis and the setup for heart failure, for cardiovascular and neurovascular insult, for diabetes and obesity, and also it may be one of the reasons why African Americans, although we're less likely to be diagnosed with cancers, when we do actually get the cancers, breast cancer, for instance, we're more likely to die from breast cancer at younger ages. Same for prostate cancer, same across the globe. So all these comorbidities, and just to give you, my timer just went off for 8 minutes and 46 seconds. So that's how long the knee was on George Floyd's neck. So we know that this trauma, this emotional trauma, that it can influence and lead to some of the conditions that we see are plaguing the African American community. We're saying that, you guys are not healthy, and this is why you're dying more. And studies back that up. These are studies looking at what does chronic stress do, and it's association with hypertension, with diabetes, the effects of chronic stress on obesity, the effects of chronic stress on cancers. Again, like I said, African Americans have higher death rates, and with more severe at younger ages for many cancers. And then this one is really interesting, it's particularly because we talk a lot about maternal and infant mortality. And what we're seeing is that mothers pre-conception, if you are chronically stressed, your child, once you are pregnant, is more likely to die before their first birthday than if they're not. And what does this mean in terms of COVID-19, and how does it all contribute? Well, if we're more prone to have this psychological stress and these hormonal shifts in our body leading to pre-existing conditions, right, then COVID-19 is not our friend, because this is looking at what are your outcomes along the lines if you have underlying health conditions versus if you don't have underlying health conditions here. And we see you have a higher hospitalization rate, higher ICU admission, and higher deaths. And just how high? Where your hospitalization is 6 times higher if you have a pre-existing condition. In your death, you're 12 times more likely to die if you have a pre-existing condition than if you don't. And these are the pre-existing conditions that we're talking about: heart failure, diabetes, chronic respiratory illnesses, and any kind of renal insufficiency. Now, we shouldn't be surprised then, right, that we're seeing this. This is looking at what are the number of cases that we're seeing of COVID-19 and the death rate. And as it stands now, this is the population percentage of white and Asians, Hispanics, Blacks, and Native Americans. And what we're seeing as far as COVID-19 cases, that Caucasians are making up about 43%. Caucasians and Asians are making about 43% of the COVID-19 cases. Hispanics, although they make up only 17, 18% of the national population, are 33% of the cases. African Americans making about 12 to 13% of the population, 22% of the COVID-19 cases. And this, the Native Americans, this can be a whole nother talk, because although they make up only 0.7% of our nation's population at this point, unfortunately. They make up about 1.7% of the COVID-19 cases, and the disparities along those lines are stark, and there's many reasons why. But we shouldn't be surprised, right? We know that you're more likely to get infected if you have more risk of exposure. And unfortunately, while the rest of the nation was allowed to stay at home and become these Zoom experts, African Americans and Hispanic Americans make up a good percentage, a good bulk of the essential workers. So they were the ones that are out keeping the food supply chain open. They were the custodial staff that we see that's walking through the halls of UVA that weren't given a mask up front while we were told to wear our masks. It was a kind of a mixed message that were given to these people. And they were the grocery store workers. Again, the people that have been fighting these essential workers for a livable wage for the last few decades. And this is just a chart that's showing just that. It's the breakdown of who works where. So this grayed out area, these are for managerial or the management and the professional settings where you work. And then the colored areas are going to be for production, for the natural resources construction, right? This is for sales and then for services. So you see African Americans and Hispanics tend to be less in these management positions and more in the direct frontline working kind of positions. And we know this. Only 1 in every 5 African Americans can work remotely from home. Only 1 in every 6 Hispanic Americans can work remotely from home. And so that puts you at greater risk. And the thing is, with African Americans and Hispanics, you can't necessarily say, oh, I just don't want to go to work. I'm just going to stay home and you can just keep my check. Because what we know is historically, that's not the only disparity that we're facing. This is looking at income levels. And this is, as you can see, from 2020 all the way back to the year 2000. And this is looking at what is the wage gap. African American women, Black men, white women, and white men. There has historically always been a huge gap, and it's interesting in that you can have a higher educational attainment. You can be more qualified for that position and yet make less money if you're a minority in that same higher position. And it's not only just income, this is looking at employment rates, right? And what we're seeing is that pre-COVID, that African Americans were always the last to be hired and the first to be fired. And unfortunately, at this point, less than 50% of all African American adults actually have a job. Now, what does this translate to? Well, it translates into income and your ability to say whether or not you want to stay home or do you have to face the fire and actually go out to work. And as it stands now, for every dollar of income that Caucasians have, Hispanics make about 72 cents, Native Americans make about 62 cents, and African Americans make about 59 cents to the dollar. And we know income is one thing, wealth is a whole different. We know historically the transfer of land and the acquirement of this wealth over generations make a huge difference, again, in the luxury of you being able to take a stance to say, I don't want to be exposed to this virus. Well, for every dollar of wealth that Caucasians have, African Americans only have 10 cents. Latino Americans only have 12 cents. We can't afford to stay home, and it puts us at greater risk. And we know that that's one part of the battle. When you have money, you can have insurance, you can have a lot of things, right? But it also impacts where you actually live. Now, it's not only where you're choosing to live because you have the money to afford that place, but also we know there's been policies in place stemming as far back as redlining of the 1930s. And redlining, for those who don't know, is literally there were maps that were etched out with red marker that said, where do we want primarily Black and brown communities to be set up? And loans and housing authorities and lenders would base whether or not they would give you money to purchase a home based on race being a huge factor. And so what we're seeing in the predominantly Black and brown communities is this high insult of industrialization. And what does environmental racism do? If you have pollution of the air and water, what does that do to your health outcomes? Looking at the incidence of asthma in Atlanta, Georgia will give you an idea of that. Or if you look at the water supply of Flint, Michigan, will tell you how greatly these policies as far as necropolitics have on the overall health of the community. You also have issues with food deserts and food apartheids, where literally there's not a healthy food eatery that's within 5 to 20 miles of your home. Instead, you have Taco Bell, Burger King, these high sodium, high sugar restaurants. And what does that do to impact the development of hypertension, diabetes, and obesity? And then you also have the lack of housing. And this is a long-term effect, because if you think about it, where do we get school funding, right? 80% of that comes from your local property taxes. And if you don't own the home, if you're having these homes that are really devalued, then you're not going to put money into the educational system, and it sets up this kind of futile cycle of impaired growth of that individual. And it is longstanding. So literally, there are studies that look at what is housing segregation in this redlining and in the continuing of these segregated neighborhoods. What impact does it have? Well, there's a study that says that if you eliminate the segregation, you would eliminate the Black-white difference in income, in education, and unemployment, because we know with gentrification, there comes a huge then push of money into the system, where the city starts to reallocate funds to build up and put that Whole Foods and put these things that we take for granted if we live in those communities that already have it. But if you're in an impoverished community, you don't see those types of things. And so that's where we are. James Baldwin, he's my greatest teacher. He says, I love America more than any other country in this world. And exactly for this reason, I insist on the right to criticize her perpetually. And I took that to heart when I first read it. And I have been a lover of criticizing America to make her as great as I know she can be, because my ancestors died for her. And so very early on, like I said, when the first death happened from COVID-19 on February 29th, I knew Black people were going to be in trouble. And so I hit Twitter like it was my best friend, of tweeting the CDC and the World Health Organization to say, give us the data. I want to see what is your racial and gender demographic. What's the makeup of the people that are getting infected by this disease? Who are we testing? Who are we giving the test? Because we know testing bias happen. And I kept writing this over and over and over again. And finally, a journalist from BuzzFeed wrote me and said, you keep writing the CDC and the World Health Organization about this. Why? Like, what are your concerns? And so I said, I'll tell you. And she wrote up this report that was talking about, my thoughts. We know racial health disparities existed before COVID-19. We should not be surprised that it's going to exist now, and we need to get ahead of that ball. And she wrote this article, and it was retweeted by Elizabeth Warren, and there was a spiral of different speaking opportunities from that point. Now, that was on March the 22nd. It wasn't until April the 8th, I think it was, that the CDC finally released their first results on COVID-19. And you can see they only chose 14 different states. And the states that they chose, I thought, was really interesting. And it actually is bothersome, because they chose states like Utah and Iowa that we know have a very, very low population of African Americans. So if you're trying to see the impact it has along the lines of race, then you would want to choose more states that have a more reflective population that the nation has in totality. But even despite them padding the numbers, what they saw was that of the residents of the states that they chose, 59% of the residents were white, 18% were Black, 14% were Hispanic. But of the people who were actually positive, 45% were white, 33% were Black, and 8% were Hispanic. And so they suggested that Black populations might be disproportionately affected by COVID-19, but we all knew that that was going to be a truth. And the thing is, most time people think, oh, well, if it's going to be a disparity, it's definitely going to be in the South. But actually, the state that has the absolute worst racial health disparity is that of Maine. Maine has a African-American population of about 1.3%, and yet 24% of their COVID-19 cases are actually African-American. And this is showing basically a heat map that's looking at, okay, what states are showing the number of cases, and then which states are having a higher number of disparities along the lines of deaths. And unfortunately, if you overlap this, the entire country is just painted this red color. just showing that African Americans and Hispanic Americans are just in deep trouble across the board. And in fact, if minorities died at the same rate as Caucasian Americans, right now, 80 Pacific Islanders, 700 Native Americans, 10,900 Hispanic Americans, and 20,800 African Americans would still be alive today if we died at the same rate as Caucasian Americans. Now, I don't know about you, but I always like to think, okay, like, why is that? What is killing my people at this point? And so this was an interesting thing on the department, our Virginia Department of Health. They have this graph that look at what are the ED visits? What are the the ED visits of people presenting with COVID-like symptoms? Who's presenting? And so we see that Latinos are presenting at a higher rate, followed by African Americans, followed by Caucasian Americans, right? And then Native Americans and Pacific Islanders. So they're presenting to the ED complaining of these symptoms. But yet when we look at hospitalizations, we see that actually the African Americans are being hospitalized more, followed by Caucasian Americans, and then by Latino Americans. This is related to every 100,000 residents. Now, if we look in totality, what we're seeing as far as hospitalization is that Caucasians are more likely to be hospitalized, followed by African Americans, followed by Hispanic Americans. Now, again, the direct opposite of what we're seeing as far as who's presenting with symptoms, but who's actually being hospitalized is flipped on in. And what is literally stated down here at the bottom of this graph is, despite their best intentions, healthcare providers may take complaints by white patients more seriously than complaints by people of color. Now, I don't know if that bothers you, but being a person of color, I can tell you it bothers me greatly, because what does this mean? It does this not taking us our complaints as seriously is literally costing us our life. Now, we have to say, my thought was, okay, well, that's Virginia as a whole, but at the University of Virginia, we do things differently, right? Well, let's look at our numbers. So very early on, my question was, okay, who is being seen? Who is being seen at our different stations that we are designated for COVID-19 outreach? And this is looking at the COVID clinic, right? And what we saw is that as far as the demographic of who was being referred to the COVID clinic, this was the issue. You had to first have a primary care refer you to be seen at the COVID clinic. And I said on the meeting that already is flawed, because again, if you don't have a job and if you don't have money, you're not going to have money to pay for a copay to see your primary care physician in the first place. And it was reflective in the numbers, because what we saw is that 76% of the people being seen in COVID clinic were actually Caucasian. African Americans made up about 11%. And Hispanics were making up about, I want to say, it was like less than like 1% of the people being seen in COVID-19 clinic. And so if they're not seen in that COVID-19 clinic, then where are they being seen? Or the emergency department. So this was a schematic. I said, okay, well, let's run these numbers. Let's see where we have an issue. So these are all the persons that up until that point had been tested for COVID-19. And we know they have a screening process in the emergency department of where we ask, do you have these different symptoms? And so these are people who screened negative, people who screened positive, the total tests that were tested, and then total positive that they had. And what we see is that even if you screened negative, meaning that you did not have COVID-19 symptoms, right? Or at least you were stating that you had COVID-19 symptoms, 55% of those who were still tested were Caucasian. Now, here's the thing. Even when you screened positive, saying that, yes, I have symptoms and I'm here trying to seek help, only 25% of those persons who screened positive were actually African Americans that were tested. Now, this is where the kicker comes in. If you look at the positive test ratio, those who were actually tested positive, who were screened positive, what we see is that 21%, the African Americans had a test positive ratio of 21% compared to only 3% of Caucasians. So Caucasians were being tested more when they weren't sick with COVID, whereas African Americans were presenting with symptoms and having actually the increased positivity rate. And so what does this translate to? Well, in looking at our hospitalizations, this was up to the week of July, July 19th. And this is looking at the inpatient demographics. So what we see is that Hispanics, right, made up about 33% of those that were hospitalized, African Americans around 30%, Caucasians around 30%. And keeping in mind the population density for Charlottesville is 70% Caucasian, about 16 to 18% African American, and about 5% Hispanic, right? And we know these are mainly community people because we say it up here. You know, we had a few coming from outside hospital and SNF, but the majority of people were within our community. So our community has a huge disparity associated with it. Now, I don't know about you. I can say, okay, well, those are adults, but hopefully we're doing right by our children, right? That we are not as a nation putting our kids at risk. But unfortunately, what we're seeing is that health disparities lie along them too. This is looking at, initially we were saying, oh, kids are not at risk, but kids were being kept in their homes and not really being exposed to much, for one. And for two, we really weren't testing kids all that much because, again, reports were saying they're not likely to get COVID-19. But what we're seeing in this summer of COVID is that the overall percent positive cases have increased by 720% for children over this short time span, with now over 500,000 cases of children having COVID-19. Hospitalization has followed the same route with 356% increase, and 1 in every 3 children with COVID-19 would need ICU admission. If you are Black, you're 5 times more likely to need to be hospitalized. If you're a Hispanic child, you're 8 times more likely to need to be hospitalized. And if we're looking at deaths, because unfortunately that does happen, we had 105 total deaths that we have counted for children. And this has been an increase of over 229%. And again, for the racial minorities in this country, 75% of all those deaths are of Hispanic, Black, or Native American children. Now, we hear this big one go around often, the multi-system inflammatory syndrome, and we know there's different criteria, but basically that means just inflammation of all the kind of organ system, primarily cardiac being one of great concern. And what we're seeing is of that subset, there's been 935 cases of this multi-system inflammatory syndrome, with 19 deaths in 44 states, with 70% of that being either Black or brown children. And you can see there's this little note in the bottom of CDC. We defer to states to release additional information on cases as they choose. And this has been a huge problem that is really frustrating, because you can't trust the data if there's not consistency in the reporting. And unfortunately, that has been politicized in ways that we're not getting everything kind of through and through. Now, that's children, right? Now we know we're starting to open up our colleges, and those are also kids. And we're seeing time after time, especially with sports now coming around, that there's reports of Notre Dame postponing games. That here at UVA, even, we've had 22 more UVA athletes upwards of yesterday. We have a total of 43 athletes that have tested positive for COVID-19. Penn State has had 50 positive. They're getting hit pretty hard. And one of the reports out of Penn State was they actually started to do some exams on these athletes, and they did a scan of their heart, MRI. And what they found was that between 15 to 30% of those athletes who had mild to asymptomatic even COVID-19 were showing inflammation of the heart. And the question is, what does this lead to in terms of risk of heart failure and longevity of this illness, and what do we do about it? So what we know as far as the NCAA is that the majority of athletes are Caucasian, student athletes, but of the high contact sports, football and basketball, 50 to 60% of that group are African American. And the question, as far as on the male side, so the question is, are we going to see yet another disparity linked in to what we're seeing with the college and universities open up and our athletes being more and more exposed? And so to wrap this up, we can see, at the present, we are facing 2 pandemics in the United States as far as African Americans. The first one is that of coronavirus. But the second one is of systemic racism, and it plays into, like I said, housing and income and exposure and risk. And how do we confront that? Being medical providers, we should be the leaders of our community. We should be the ones pushing for change. And so the question is, what are we going to do about it? And how are we going to make sure we're holding ourselves accountable for how we contribute to the disparities that we see? And I'll stop there. Any questions at all?
Well, Dr. Hilton, thank you again for doing this on the last minute. I really, really appreciate it. I've been following you on Twitter for quite some time, and you're always thought-provoking and provocative in a good way. I think that one thing that we can do is just keep talking about it. And so I know you and I have talked about this a little bit, like at what point does it become kind of overwhelming? And I just think we have to suck it up and be overwhelmed. I mean, like it's just out there. It's real. It's very easy. And I've, as a white male who's 56 years old, to be focused on my career and my life and my family and just not understand what's happening because it's not impacting me the way it is impacting others. And so I just think we have to keep talking about it. I'm struck, and I'm a little embarrassed too that some of this stuff I didn't know. And as I go back and watch some of these movies and read some of these books and stuff and, learn more about James Baldwin and stuff, the rhetoric is exactly the same. I mean, it's not any different. And it's just stunning to me. And also, unfortunately, some of the political strategies that are being used are the same ones that were being employed in 1960 something, right? In 1970, and the rhetoric is exactly the same. And so the more things change, the more they stay the same. So I appreciate you sharing that with us. Other comments and questions?
Ebony, hi, it's Mike Williams here, and thanks so much for giving this important talk. You and I have also talked about a lot of these issues, and thank you for your leadership here at the health system. I think we've been a bit lacking and a bit behind the curve, as you also well know. So Dr. Mark Fleming and I from our department have a piece coming out in which we, in a policy journal, that we actually describe a third pandemic, and I want to hear your thoughts on what you think about this theory. That the first two you've already described, but the third is going to be when it comes to vaccine access, uptake, and utilization. Our concern is that, and I'm very, very certain that the data show this because I've written about this myself. COVID is actually not any different than any other disease that kills disproportionately, as you laid out so nicely here. COVID just does it quicker. And there may be a longer tail, as you point out, with the myocarditis and the things that we're going to find out with chronic lung disease or for survivors of this illness. But the access and use of vaccines is something that has a real bad taste in the mouth of a lot of Black people, as you well know. So I wondered if I can get your thoughts on, will we see a third pandemic where the pandemic is because either we are not offered access to it, which I think is going to happen for sure, because that's also a legacy of this country, or are afraid to access it because the legacy of racism in this country. So I'd like to hear your thoughts on that, if you don't mind.
Yeah, that's a great. I was literally trying to find, because I had a slide. I think I must have deleted it. In looking at, it's already showing itself as far as it's going to be a disparity. So Moderna had to literally pause their. So we know there's like 120, I think, vaccines that are in play right now. Moderna had to pause their trial due to lack of diversity of their participants, that African Americans were not volunteering. And we cannot fault people. I mean, honestly, the Tuskegee trials, Tuskegee, and everyone I'm sure knows about the U.S. public health system, that we're doing experiments on African Americans and trying to see what does the progression of syphilis do to a person. And this is between 1932 to 1972, when we knew that syphilis could be cured by penicillin in 1940, but it was allowed to continue on. And so this was a whistleblowing at 10 years before I was born. So people very much remember this. And if that's not, recent enough, then Flint, Michigan, with the dirty water being sent to people that we know this does not look like clean water I can drink. And yet we're telling people it's okay. The distrust is there, and it's is grounded in truth of why there should be some. I think the medical community, we have to earn that trust back. So there's been big pushes now. I'm sure you've heard about from the HBCU. So I want to say it was Meharry and Xavier. They're asking the upper leadership is asking their students to actually volunteer to be vaccine test takers, because it's been a hard time finding Black people in the community to volunteer for this. And I have kind of mixed feelings on that too. It's I would be more than happy to volunteer. I think to ask a student to do it, it's a little bit much. I don't know. So yeah, I think we will have a disparity, but I honestly think COVID-19 is to a good portion of white Americans now, that Tuskegee, I feel like, and it's not the same, let me just say it that way, but Tuskegee is for the Black community distrusting medicine, right? COVID-19, with the politicalization that has happened and the changing, we saw from the CDC, there was a message put up about, this is the way this is being transmitted. And we've been knowing these reports since April, May, that is aerosolization of the virus that can also possibly be a cause. So it was put up briefly and then taken back down. Politics. We see, these taunting of, oh, it's a hoax, and then don't wear a mask, do wear a mask. And it's caused a lot of distrust. We see the rallies, right? And how we as a medical profession are going to bridge both those gaps of huge portions of our population not trusting what we say, not trusting that they even need a vaccine, or not trusting that the vaccine, if they do get it, is going to be safe. In a virus where we really don't have much by way of treatment options for it, if you get a severe case of it, I feel like we are in some big trouble, and we're going to have to start hitting the grounds, really talking to people. And we should have been doing this, especially in Charlottesville. I feel like we should have been doing this way back in March and April, so we could really start to get the community's mind wrapped around what is going to happen next. Because now we're seeing, you saw President Ryan last night had to release a statement changing the restrictions on the UVA campus, because our numbers in our city, and definitely on UVA's campus, are starting to tick up, right? Nationwide, we're starting to tick up. And Charlottesville, as beautiful as it is, whereas New York City has 62 hospitals, we have 2. And we can't afford to have an outbreak. We don't have enough personnel as far as persons to relieve each other, and we simply don't have enough resources to take the mass of people that we could potentially have. So I think we definitely need to get ahead in communicating with the community better on prevention of spread, but then also how do we introduce the vaccines in a way that they don't feel like they're being forced to take it, but they understand enough about COVID-19 that they want to take it. Yeah.
Thank you.
Any other questions?
Hi, Dr. Hilton. It's Marky. How are you?
Hi, Marky. Good.
Thank you for such a riveting talk. I feel like you just schooled everyone who is listening, including us who are more aware of some of these issues. And, as we were talking about vaccines, the conversation comes up between us as healthcare providers as well, and Black and brown healthcare providers, and whether or not we would be willing to take it. Mm-hmm. And as educated as we are, and as much as we understand about how vaccines work and the importance of them, I still find a lot of us are hesitant to admit that we would take the vaccine, myself included. Mm-hmm. And so how do you, what sort of advice do you have for people like me who, there's a certain level of mistrust given the history that you've perfectly described, as a healthcare worker who might be asked to take this vaccine as one of the first set of cohorts? What do I do? Because honestly, taking that vaccine makes me nervous too, especially given the speed at which it's being developed and all that sort of stuff.
Right, right, for sure. I mean, as you know, the warp speed that this is happening, it has not happened like this ever before. Now, the technology is different. The way we are actually creating these vaccines are different, right? We're not growing them in a chicken egg anymore. And so there are differences as to why it's being pushed through faster. Now, what I can say, when AstraZeneca, this was what now 2-3 weeks ago now, I feel like, when they paused their trials for the second time because there was a case in the UK where a woman developed transverse myelitis, right? And they were trying to see, is this related to the vaccine or is this related just to something else? That actually, where I know other people have made them have a pause of like, oh, I'm definitely not taking this now. That actually made me feel a little bit better in that it shows that they are following the proper things that should happen when you're developing a new drug. They were upfront about it. They released the data. They said this is what it is, and did an investigation, as we should all do in the scientific field. Now, I know there's already reports that in China, I think, and in Russia, they're already vaccinating people before the third or phase 3 was completed. I would not volunteer for that. Like I want a full, a fully tried drug before I would necessarily inject it into my body. But it is one of these things. I wrote an op-ed not too long ago that, as a African American physician, I take my white coat off. At the end of the day, I'm a Black woman, and it is scary to know that I might be a statistic of the very system that I'm playing into. And what do you do with that, dichotomy? And how do you take a leap of faith to say, I'm gonna trust this system, knowing what I know, and especially knowing what the data shows that, if you're symptomatic and you come in, they're not gonna, according to their best interest, they may not take your symptoms as seriously. What do you do? And so I do want to protect myself from getting COVID. I know that, I'm healthy, and I try to live a healthy lifestyle. But what we know, studies show that even with higher income level, higher educational attainment, living in a better community, all the socioeconomic status markers that say you should be fine, African Americans have worse outcomes than white people with lower socioeconomic status, lower educational attainment, living in a worse zip code. Our outcomes are worse than them. And that's along the lines of cancer mortality. That's along the line of maternal and infant mortality, cardiovascular, neurovascular mortality. I mean, African Americans, we have, in all the 15 total causes of death, we have 9. We lead in 9 of those. And so, you can't buy your way out of it. So I think it'll be a leap of faith for me to just jump off the cliff and take the vaccine. But for the betterment of my people in totality, I want to make sure that it works. And so if there's a trial that happens here at UVA, I guess I'll sign up.
Well, thank you for being so honest about that.
Yeah,
that's definitely something I'll be struggling with for a while, but I definitely understand the importance and the need for representation.
Yeah.
So thank
and
you.
it's important. I mean, in Dylan, I'm sure you guys have talked about this in your department, but like when all this first started back in March, April, I immediately started to write. Well, I say all of our students, minority students, but in our department, it's a little slight on that. Because I'm the only African American attending, and so I felt it weighed on me to be the person to reach out to them and say, "Are you okay? Like, how are you doing with these deaths that you're seeing, not only on the protest side of things and people being shot, but how are you dealing with the patients, the COVID-19 cases, and knowing that you're coming into work where you're going to be on the front line and possibly being exposed to this? What does it do to your mental state?" And so I hope the same thing has been happening for you, because I know that can be tough.
Thank you, Az.
I have a follow-up question actually to that. And first, thank you. It's been a pleasure getting to know you as a colleague, but then learning also everything else that you bring to the table, including this database and wonderfully contextualized presentation. But related to vaccination, we have mandatory flu vaccination within the health system. And if we get to a state where there's a phase 3 trial completed, I'm going to be totally fine with having mandatory COVID vaccination myself. But recognizing that I come to this with a different background and context than others, what are your thoughts on mandatory vaccination within health systems or certain lines of work?
Honestly, I think when you force, clearly we're seeing that with mandatory masks even being discussed, there's protests and going to the Capitol and people going with guns to the governor's mansion, right? And that's just with a mask that you can take off. I honestly, when I think about us mandating a vaccine, I mean, I just don't have much hope that we're going to be able to force that at all. I think we're going to be met with a lot more. And even at this point, I'm not even so set on people even getting the flu vaccine this year as readily as they were before, because there's so many conspiracy theories floating around about, oh, they're putting, there's conspiracy that they're putting COVID in the nasal swab when they're swabbing you, and that's why everyone is positive. And so, are they going to think, oh, they say this is just a flu vaccine, but they're sneaking in I don't know. And again, I think that's why in medicine, I feel like nurses do a great job of this. I think they do a great job of leading with their heart, and the community, when they think of a nurse, they think heart first. When they think of a doctor, they think we're leading with our head and or our wallet for whatever reason. But I think we need to get our boots on the ground and go and start talking to people and hearing their voice and trying to educate them, not in a I'm telling you this, but we're talking about this. And that might be our best bet, because when I went and did some testing with the group on Friday at the UVA campus, and even as we're swabbing some of the UVA students, there were a couple of them that I could tell they thought this was just it was a hoax. They didn't believe this was real at all. And so we're going to be I feel like, in an uphill battle. And again, we've had 7 months to prepare for this, and I still feel like we don't have a plan. So we got to start. We know what the problem is. We don't need any more data. We need action.
Yeah, Phil, if I could just riff on that in the last couple seconds here. So I think to Ebony's point, mandated anything is going to fail in this country because of the freedom-loving population that we've seen so much of on TV and the news, and protesting down on the downtown mall a few years ago. I'm actually much more interested in having wide open access for frontline staff be the first thing we talk about as a mandatory thing. So once there's a phase 3 clinical trial that proves that a vaccine is effective across populations and across the lifespan, once that's true, the first people that need to have access to it and should not pay one penny for it are these same frontline staff who've been coming to work, who came to work unprotected in the first part of the pandemic and are now struggling to make ends meet and pay mortgages, rather than having a focus and a conversation with the community that we'll be having, obviously, about mandates. It should be, here's an offer of a thing that we are also saying is safe because we've all taken it, right? To sort of shut down some of the fear, is that if at the same vaccination stations that we are offering this to UVA employees who are physicians and other frontline clinical providers, we're offering it to people who are non-clinical but also frontline essential workers. That statement is one that we could make in a resounding way that would speak to the community that I know here in Charlottesville and in the region, that says we do care about you, as opposed to the way we've treated them for the last couple of years around here. So I think if there will undoubtedly be mandate language. I think it's the wrong approach. I think we need to talk very critically about co-creating this with community to say how is the best way for us to deploy these new technologies, because a vaccine will in fact be new technology. We mentioned self-driving cars and M&M earlier. this is no different. How are we going to sell that to the community? Well, it can't be a sales job. It's got to be a conversation.
Mm-hmm. And with UVA being a #1 employer around here, I mean, Charlottesville City itself, at least, we're not that big. I mean, what is it, 40,000 people? So with herd immunity, you need at least 60%. If we, as a university, are able to, champion for it, and then target some of these other big companies that are around here, and we may be able to create a little bubble, get the students, to, because yes, there's a lot of tourism, I think, to Charlottesville, but usually I would assume, I don't know, I've only been here for a couple of years, but I would assume that's mainly during the summer months when people can go to wineries. And so during the winter months, we might be able to get enough people vaccinated within the city itself that we can create a wall around ourselves for a little bit. But yeah.
And I'm assuming, Dr. Williams, you were referring not just to healthcare providers, but to the custodial staff and the people in the grocery stores and all the people
100%.
Dr. Hilton was talking about that are the true essential workers.
Yep.
When we call us heroes, I'm not totally sure, we're not the only heroes out there.
100%. That's exactly what I was talking about.
Yeah, so it is 8:58, and I want to thank Dr. Hilton again for doing this on the last minute. I just got a text from somebody, and I'm not going to say who, but the text says this is very eye-opening. So that's exactly what you were trying to accomplish. So, I love the fact that people are seeing this, and I appreciate you sharing with this. And I guess in some ways, I'm sorry you have to share it with us over and over and over again, but nevertheless, it's important, and I appreciate you being the strong voice that you've always were, but clearly it's now become a national voice, which is really exciting for you and us as well, quite frankly. So thank you.
I mean, what's same for you though too, Dr. Frill, and Dr. Williams, I follow both of you on and Marky, follow you guys on Twitter. Allies, I think in this moment we need to speak up on this, and I think you go to the point of being anti-racist in your post, which I think is it does a tremendous lift, because like I said, it is exhausting as minorities to always have to teach about this. It's emotionally draining. Every time I give these talks, it's emotionally draining to talk about your people dying. So passing that torch off to other people who may not have that same emotional sting is helpful. So thank you.
All right, let's get back to work, everybody. Thank you.
All right, thank you. All right.